Today on this trauma module, we have a very special guest with us, Professor James Hui from Singapore, and he's going to help us understand sports injuries in children. Over the past 3 months, we have gone through fractures in upper limb, lower limb, understood the treatment in details. This time it's time for sports injuries, which uh, Indian audience usually doesn't have a lot of expertise, and we usually have our sports colleague or arthroscopy colleague help us. To understand us better, we have Professor James Hui from Singapore, and I would like Dr. Maulin Shah to introduce him in detail and tell us more about the POSI academic fellow meetings.
So
Over to
thank
you,
you.
Maulin Shah.
Thank you, Chintan, and welcome, Professor Hui. It's a proud privilege to have you here today in POSI Orthokids Fellow Teaching Module. So let me introduce Professor Hui first. I know that he does not need much of the introduction. He's so popular in India. Professor Hui is a leading pediatric orthopedic surgeon in National University Hospital, Singapore. He's head of the department, and he is also serving as the Ling Chow Ming Professor at NUH currently. Professor Hui completed his orthopedic training from Singapore, and then he pursued his fellowship training from Australia. And he is a big name in Singapore because he started stem cell based cartilage repair in children. And his key interest is not only pediatric orthopedics, but cartilage repair and regenerative medicine, which is an upcoming topic. And although the sports injuries are not that common, but we see a lot of accidents, road traffic accidents, and now the sports is coming up in a big way in India also. So every now and then we see these sports injuries, and it's high time to get aware of the latest sports medicine topic. And I'm pretty sure that this today's topic and talk by James we will stimulate and will teach us a lot. He is heavily engaged. He's a professor and head. He's a surgeon. He's a researcher. He's an educator. Through his liaison with POSNA and APOA, he's teaching so many students all across the globe. And we are so fortunate that many senior colleagues in POSI have got their training under him. So thanks, Professor. Thanks for being here today. A brief about what is this fellows teaching module. So we have started this teaching module before 5 years, and it was limited to Orthokids fellows, alumni initially. But as we started, it kept on progressing to different institutes. So in India, and India is a big country. So we had around 360 fellows, part of this fellows group all across India. And last year, with the effort of Dr. Jayan Sampath and Viraj Shingade, this Orthokids teaching module has now become an official POSI Fellows Teaching Academy. So every Saturday we meet, and today is probably 160th Saturday webinar is there. So we welcome you, and we all look forward to hear from you. Very warm welcome.
Thank you. Thank you. Let me see, share again.
Yes, please.
I do have fair bit of slides, so that means I won't be doing too much of interactive, because otherwise we'll be here forever. So sorry.
No problem. We'll spare a few minutes at the end for some about 10 minutes for discussion or questions if people have. But you take your own time.
Okay,
no problem.
okay. Sorry, you can see that I'm in the
No, your slides are very well visible, and we can hear you well. Thank you.
Yeah. Okay. Sorry, I'm actually in the hospital, and we just finished ACL. Unfortunately, the kid got no meniscus, so I can be in time here. So really, indeed, an honor and a privilege, and definitely I just like you say, in a way, I need no introduction to India because just yesterday I saw another patient from India, and I told the patient proudly that have yet to find another don't talk about the doctors, but any Indians from Singapore who have been to more Indian cities than me. So I'm still holding the Chintan, the proud record of 22 cities. Yeah, in that I have visited in India. Okay, let's go. So it's a quite a big topic to cover because I really like all your topics you show before in your fellows thing. Then you are like very quite specific things like radio neck and all that. For me this one a bit too much to cover. Briefly, as you all know, many of you been to Singapore, welcome in the airport. Yeah. And then, of course, the usual Malayan and Gardens by the Bay. And, I just hosted this think tank, pediatric orthopedic think tank meeting where members from India are, I think, Visha and also, of course, Benjamin Joseph, but I think we are, then Alaric, but Alaric
Alaric must be
wasn't
there. Yeah.
here last year. Yeah, but I think we should nominate more people to get in. So they were here, in the Gardens by the Bay, and you could see here, we do have some other than Visha here, although we have like
Sure.
your Indian exports. We have Visha and Kishore, and also I think, can you make out where Uni is? Is that Uni?
No, not there.
Is that Uni? But how come he look like blonde? No, but Uni is definitely here. One of them here. Yeah. Yeah.
Okay.
So we came, of course, then in the center here, Prof. Lee, my mentor, and then Colin Mosley was here as well. So
Yeah.
you can see everybody. Yeah, of course, this is like my campus now. Qingdang has expanded beyond recognition, even at your the time that okay. Okay, let me chat with them. I don't know why they say sorry, Ayo, there's some I had to I will tell them. Hi, please put up the admission. They can't find the record. Okay, sorry. Yeah. So this is the campus is really, a medical school with all the 5 different buildings in the hospital. And of course, we have a standalone children's medical center. Yeah, 1 block by itself. And then this is the huge department, of course, including everything else like spine and arthroplasty and sports and all that. But why I show this because we have this fellowship for years, and now Qingdang has improved even better now. So in terms of fellowship salary, they indeed, for if you are taking first fellowship, then this is the pay, and then if you are doing a second fellowship, we actually pay you quite decently. Marlene, do you think this is quite decent for if you're second fellowship, 450,000 rupees?
Oh, yeah. I mean, fellowship it's an investment in education. So I think whatever money they get, but they should be able to sustain their expense.
Yeah,
But
this I think is more than enough, and
yeah,
with all
yeah.
that. So it's
What is
quite,
important is they are getting a lifelong,
yeah.
Yeah.
Okay, so I cover the topic today. It's very broad. So why is that? So just late last year, I was invited to Boston Children, and you could see some of the sporting guy, and then this is James Kaiser, and they also doing now grand round in rooms and then being broadcast by Zoom. So no longer like last time, people come together and
National University.
a big area.
In England है क्या ये?
And then, sorry, then I also celebrated my birthday with the lobster. But why I chose this is because this is Mary Martha, they are the head, and I'm sure Marlon, you know Don Bay well because of elbow and
Yeah,
shoulder.
yeah. From Boston.
But why I show this is because you look at the TV screen behind, a crazy place. Boston's quite a small city, maybe 5 million people. But you see how crazy they are. They have Patriots who the American football and champion, and Boston Red Sox, the baseball also some champion, and the Boston Celtic in NBA also some champion, and then the ice hockey, Boston Bruins also a very good team. So of course, other than football, soccer, they are the weakest. But one city can have a 4 champion team, it's like so, and also that tells you how the craziness of American sports. So, and I think Singapore gradually moving towards that direction, and I think India probably lag behind, just like Indian Olympic, right? I always joke with my good friend Din Shaw that every time you need Din Shaw to win the Olympic gold medal for Indian athletes, he always operate on one, then win the medal. So this is what I brought a team first, 2025 to Columbus, Ohio, a very small Asian team. Then this year, a much bigger, then covering Australian, Japan, Korean, and Sachin as well. So it's like a lot more. This prism called pediatric research in sports medicine. So I hope some of you get interested in sports would join us for this. And why I show you this is what publication in sports. You look at this, you look North America in red, Europe in blue, green Asia, and you can see that, ACL, osteochondritis, patella, discoid, these are the prominent publications in pediatric sports, right? Then you can look, my God, it's almost, Asia, right? Really, we are tiny. I mean, you're talking about every Asian country combined, such a small representative. And if you put into the different condition, again, they simply dominate. But the only one condition is in Asia, a bit more is discoid meniscus. Yeah, but the rest really like very few compared. And so I come down to tell you about this is an article from Boston Children again. They show that if meaning the children before the teenager and adolescent, then you can see that who will have more traumatic, who will have more overuse. So, and then it tell you what are the types that get more injuries. Some get more apophysis, get more meniscus and ligament tear, all that. And of course, surgery rate will be higher in the adolescent age group. Yeah, so I will cover, it's like quite extensive, but I will try to rush a bit so that I won't take too long your time. I will go through a shoulder, elbow, hip, knee, and foot ankle, but I will really focus on the few conditions that being highlighted in the publication that well published in the world around the knee, basically, all those 5 conditions. But the rest I just go through so that you're aware of them. Shoulder, so very funny, clavicle fracture, in India probably called trauma, but in America it's quite funny, is because it's related to sports. So the woman is sports injury, they get insurance claim, but if you're trauma, you don't get claim. So you can see the increasing rate of surgical fixation, even among the adolescent, which of course is very questionable. I think we are still being very conservative on that. I think although I may operate a bit more on the adolescent, like towards the end of adolescenthood rather than anything earlier. So anyone earlier, like 14 or under, I think we would not touch them. Okay. And shoulder, of course, anterior shoulder instability like Bankart and all that is very common. It's a huge topic by itself, but most of these kind of cases we cover by the shoulder surgeons. And of course, this again about pediatric shoulder dislocation, and again the incidence on the rise. Then move down to elbow. Elbow is, what, commonly this is not chondritis discans, this is osteochondrosis, meaning that you see a lot of the changes you must recognize in the capitulum, but don't go and jump into operating on them. They are not OCD, okay? Yeah, so they are all these sometimes can be overused in the gymnasts and sports and all that. However, elbow OCD is a distinct by itself and is really as common as knee OCD in a lot of the upper limb sports like baseball and throwers and all that. So beautiful cases, and you really had to do a lot of elbow scope because you need them. Yeah. Okay, the next one. So that's how you do it, and then you have got this OC fragment, and then you can fix them with smart nail. So usually what I do is I do the scope to look at where the lesion is and look at the size, and then I actually tend to do a open surgery. The reason is for scope, I don't dare to fix them as perfectly as this because this run give me a very nice contour and 90-degree to the fragment. So, and some of the patient, another sportswoman, really, really good 9 months post-op. And my best case is this champion went on to compete in Australia, same thing, the OCD, 9 months after surgery. So you can see that it's a very satisfying thing. So you move down to from elbow to wrist. This again is like overuse in all these gymnasts and the sports girls, but they are not fractures. Okay, so I come down to hip. Hip is, I think a lot of them will have encounter in so-called trauma, whatever. A lot of time, these kids who play, sometimes even just play a fool. They jump with friends or in football or I don't know whether you all call soccer in India as well, and then they had like that pang, and then you could see after that patient will have difficulty in like moving their the hip flexors per se or even quadriceps. Then you can see just a small fragment down the ASIS, but we almost never operated on them because they all heal, even though sometimes may not look perfectly healed, but 3 months post-op and patient is asymptomatic, and actually in 4 months they are back to kicking football again. Yeah. Then of course another pop, another hit. You see that? Huge fragment here, and then again 3 months, and this is a AIIS avulsion. So you see that, very nice and X-ray healing, and as long as you diagnose them, and this patient do very well. Okay, then this is one area that I only operated on 2 cases in my life. In the younger days, I try to be itchy hand. They do got a huge hamstring avulsion. And then Maolin, I really regretted because it's a lot of bleeding and a lot of hematoma, and not a fun thing to do. So this is so I would not advise anyone, even you are so itchy hand, to go and operate on a hamstring proximal avulsion fracture, although it's very tempting at first. Okay, then I move down to knee. And knee, I will just cover those areas not in the 5 I mentioned earlier on. So things like Sitting Larsen-Johansson syndrome, this patient, a lot of these are again overused in the inferior pole patella. And then you can see that sometimes this, but they could initially have difficulty in extending the knee. Then later actually heal very well as well. So really conservative treatment. So these are the things that very uniquely spots. So good for you to know, good for you to diagnose, but they are, I will put it under the non-operative area of the sports medicine. Okay, then come down for ankle, very common, of course, ankle instability, recurrent ankle, a lot of such cases, tons of them. But I'll introduce to you like things like os trigonium, really are the one that getting also more picked up and more common, and then patient can see. And also, of course, you must be very, other than recurrent, like ATFL, all that, remember, when they have recurrent ankle sprain, think of Taylor OCL, okay? So very similar to what, OCD you see in the knee and the elbow, and this is like the lesion. And this one, usually we try to do drilling and all that, and eye guidance, and they do quite well with it in children. All right, so and these are the incidents ankle OCD. So now I'm going to go through the rest of the so-called 5 big topics in a bit more detail. All right, so then now I really come back to our own Asia Pacific papers. So you can see the ACL still, we publish more ACL, and but 2 areas like patella and OCD as more common. Then of course tibial eminence really small. Why I just show you all this in a bit of give you an idea what sort of cases we are seeing, we are reporting in our part of the world ourselves. Okay. So first, discoid meniscus. Discoid is very funny. I don't know. How common are discoid in India? Maulin?
Yeah, it's fairly I won't say very common, but over last 23 years, I come across around 10 discoid. And then I was visiting CMC Vellore, and Thomas shown me the database. They was showing me the software. But they had around 78 cases of discoid. So they have a fairly huge number, and
Yeah.
we see maybe few a year.
I used to, we used to think that, the Korean, Japanese, and the Northeast Chinese, but now, I mean, recently I do have fair number of discoid meniscus of Indian expats in Singapore. So I would say that I think maybe previously not so picked up. Yeah. Okay. So that's what it's like. And diagnosis. Actually, I made a video for Posna. It's made by so you can get this very nice. Yeah, and then we try to do this. Of the knee. Let me see. Can be demonstrated by using one hand stabilizing the femur, and while the other flex and extend the knee, and you're holding on distal tibia. And you really get the plank in extension as well as flexion to 70 degrees. So you really, I think a lot, the moment a child come to your clinic with clunking, then you must think of meniscus. Discoid meniscus carried out by using anterolateral and anteromedial. So these are huge bulk here. Complete lateral discoid meniscus is shown here. Huge bulk. Careful assessment of the disc. So then you sosterization by shaver is usually difficult. That's how you do it. Of the roundness of. And then we mark out the margin. After the assessment of meniscal stability, yeah, we then mark the resection margin with radio frequency ablation to guide our. The recession margin of the sosterization are marked out. And you really had to bite gradually. 8 millimeter of peripheral meniscal tissue while recreating. You need a fairly sharp instrument. Meniscus. But here I like to show you is that, can you see as I biting, is that a lot of the reset the central portion, the tissue, right, is very, very unhealthy. You must appreciate that how unhealthy the discoid meniscus tissue is. And then after that, you stable. A lot of them have a tear inside, so you need to do a repair of the meniscus repair inside. Placing one stitch. So after complete suturization of the bowel, then you check your stability again, make sure at the back, and then meniscus volume is reduced, and the standard crescent shape. And then you can see that you saw, right, restore the. We demonstrated how all inside meniscal repair technique can be used in conjunction with suturization. But the key here is that meniscal tear with mucoid degeneration and meniscal instability. But the key here is, I like to emphasize is that don't make it too big. Don't previously I really exercise until like so patient got no more clung. But the thing is, if you do that, you find that yes, symptom wise they improve, but in the long run, you really try to preserve as much meniscus as possible. So nowadays, I just do enough and also bevel them enough so that you preserve as much meniscus as possible. Even though patient may have a bit of clung or cling, I will tell parents and children that please tolerate. I'd rather you have some meniscus left than totally no symptom per se. So that's what's like you try to compare, like I try to preserve fair bit left, just do minimally. So I would say the less is more or more is less. All right. Then a lot of them nowadays have bucket handle tear as well, even with discoid meniscus. And then I try to, after done that, and then repair them quite crazily. Sometimes you can put in, like 7, 8 stitches inside the lateral meniscus alone. Yeah. All right. So next topic in the knee we cover will be OCD, osteochondritis dissecans. Yeah. So, and this is again very common, and patient would feel clung and also got some catch and pain. Yeah. In fact, I think one of my patients from India he actually did a YouTube channel on the journey of bilateral OCD. Why he's so interested in it? Because poor guy, he had it for 2 years, but somehow different doctors saw him fail to diagnose OCD lesions on both knees. Yeah, so classically, would be on the lateral aspect of the medial femoral condyle. Okay, so this so-called the watershed area. All right, so something like that. You do your MRI, or you need to look at whether there is a lesion that is stable or unstable, whether there's water level, fluid level in between. And sometimes I also did CT to look at how sclerotic the bone fragment is to determine whether I can treat this with antegrade or retrograde drilling instead of fixing it like what you saw on the elbow case. Okay, so, and this case, we actually use navigation because just want to minimize everything. So this navigation thing is very nice. It gives you the precision. It's a lot more accurate than image intensifier. And then we get to see the drilling, the bleeding, and so we go to the area to look at how it's like. So intra-op, you can image, and then for this case, not just drilling, I also give a BMAC as well. And then this patient is 13 months post-op, and she's back to sports again. Next big topic, of course, patellar instability, but you know that patellar instability will be like a huge topic by itself. So I wouldn't cover in detail, but suffice to say, I give you one summary slide. Basically, I feel that it can really be an a la carte approach. And if you know all the risk factor and all the underlying pathogenesis of pathology, then you correct all of them, they'll be correct. So you can see that, they do have miserable alignment syndrome or whatever, then you get excessive femoral anteversion, then you can do derotation. Of course, you get too much genital valgum, and you can either do osteotomy or you can do a plate if your patient is skeletal immature. And then coming down, if a trochlea is dysplastic, then you can do a tracheoplasty, a deepening groove, and then your medial MPFL is injured or incompetent, then you can get your MPFL reconstruction, and patella is too high, you can distalize it. And then your tight structure is too tight, you can do your lateral tight structure release. And then you know that excessive tibial torsion that you can derotate again. And just like it can be in the form of TTTG too much, then you can medialize it.
Yes,
So the whole thing. Then in this case,
maybe go faster lah.
so
I know
this is a
is slow.
habitual
Yeah.
dislocation infection. So
Faster, yeah lah.
this one, the main
Thanks.
pathology here will be tight lateral structure and also very short quadricep mechanism. So you can see the treatment here really is to lengthen and also release the lateral structure. So quite different from next one, where this is really the J sign.
Slowly.
Yeah.
Bend. Right knee. Bend. Okay, both knee.
Okay. So this
Yes,
is
correct.
so,
Bend. Good.
yeah, so this would be a classical J sign and extension, and therefore the surgery be really towards looking at the trochlea and also like other deformity like TTTG increase and extra APFL incompetent. So hence, this is one of those things that you can do tracheoplasty on them, something like this. So it's that you guys see this very very prominent trochlear dysplasia type D, and then you can see post-op you create better groove. Okay, but this is one slide. It's the biggest interest to me for especially young surgeons. This is something that when you see a patellar dislocation, you cannot afford to miss this tiny Maulin, can everyone see this tiny flick there?
Yes, Prof.
Yeah.
Osteochondral fragment.
Yeah, so this one that really for younger colleagues, you really have to pick this up because in emergency, this is probably the only single absolute indication for surgery, either to fix it back or to remove it. Failing to do so, they become a joint mouse and become a loose body. And in Singapore or in America, the lawyers certainly come after you. Okay, so that's what patella. Of course, tracheoplasty nowadays also you can do it by arthroscopic. But I said I took damn long, I think 3 hours to do this. Terrible. So this is a tibial eminence. Probably you as a pediatrician see more than the adult sports surgeon. Okay, because adult sports surgeon don't really get this sort of case going to them at this tender age, because these tend to be very young, like you can see really like growth plate way open, and then they're like all in the region of like maybe between 8 to 12 years old. And you can see that nice tibial eminence going up, and the mercurial classification 1, 2, 3, 4. And usually you can do MRI also to look at whether the ACL, not just a fragment up, but how bad the ACL was stretched. Because sometimes even fixing back, in the long run, the ACL also are not as perfect as it should be. But nonetheless, and also you do the MRI to look at whether the meniscus are being trapped under the the
Eminence.
correct, yes. All right. Then and usually I like to also do a CT to look at how fragmented it is when we do our fixation. So fixation can be either screw or suture anchor, really up to you how comfortable you are. But typically, once you open up, you must really get it very clear. Look at the base. Try to get the base very nicely sorted out so they're really fresh, like try to almost like reducing a fracture. So make it beautiful. And then after that, also you also sort of like take away all the flaps or meniscal that been trapped underneath the ligament and all that. Then after that, you try to reduce it and temporary fix. Yeah, so that's the temporary fixation. And then you can see that we passing a lot of wires as well to, and nowadays previously I used to fix from the proximal tibia up to create the tunnel, but now I tend to do it really above the epiphysis. The reason is by doing this, the suture anchor to the fixation is very short distance, so you get a more oomph, more catch on this. So you can see that a huge fragment here to pull it back, and then you just pull back on the proximal tibia. And then, quite beautiful. You can see that the same patient 1 year after fixation, you can see this is where our tunnel was to anchor our suture anchor for the fixation, and it does not affect the growth plate, and then the patient back to spots again. Sorry, someone called me from the hospital. Sorry. No problem at all. We will just wait for the afternoon. Okay, good. So next, the topic coming down will be on the ACL proper. So ACL in adult is a huge topic, and ACL in children becoming also a big topic in America at least, and here in Singapore as well. And they say that, wow, after that, can you still become a elite athlete? So they say that maybe about 1/3 become an elite athlete. However, after that, sadly, they will tend also get another injury, so not such a fun thing. But nonetheless, we're getting more and more such patients. So first one would be like, very young. This is quite a crazy kid that play football actively and with encouragement of the parents. And then you can see that really the growth plate are super open, right? You agree? Like really I would say tenor like 1 or 2 kind of thing. So these are the patient. You can see that you really the whole ACL disappear, and then even the patient had meniscal injury as well. So, but because so young, so we decided to do this very Boston technique over the top, and then you have to harvest a long ITB as broad as possible. But then of course, in view of the scar, then we try to do this funny thing, cosmetic incision. Yeah, 6:30. Not very cosmetic, but nonetheless, I try to harvest and then up and down, and then you come out proximally. So that's like, I think 15 centimeter in length. And then after that, then you do your over the top. So when you pass this graph at the back of the femur, and then you can see that you use a suture anchor. So I must say, with suture anchor, it make a lot of difference in terms of rigidity of fixation. Last time they just loop it around, using staple, even worse. So I think suture anchor is beautiful. You stabilize posterior to the femur, and then also, remember I told you all I like to fix things near the epiphysis now. I don't want to come down here, so that all your fixation is very near the actual origin. So the tibial tunnel is here, and then you over the top. So just pass under the meniscus, and then you fix this with a suture anchor, and then something like that. Yep. So, and then because patient had meniscal injury, we also repair the meniscus, and at the end, even is I try to take as broad as possible, but in the end, it's not very broad intra-articular segment. But remember, because it's over the top, so it also have a lateral like a LET kind of structure. So it got a double thing. So I'm proud to tell you that my friend went back to play football like now at least 2 years post-op, and then he's like happily playing without no re-tear or meniscus and all that. So it works. Of course, another one is all epiphyseal technique, meaning that patients slightly older, not so young, like 9, maybe 11 or 12, but physes are still open. So this is what we do. See that? We try to pass in epiphyses and come down in epiphyses. Okay, you see that? Epiphyses, epiphyses. All right, so this one you have to be very precise. So what we do is before the op, we measure the patient, and then we actually try out to see how many millimeter we are doing, and then we use a model to try out first. You know, like it's always good to try out, then you drill first, all that. Then this is what II is like. You know where your tunnel should come out, and then this is AP lateral where the femoral tunnel is. Okay, and then femoral off guide, that's how you drill. And femoral guide also use a flip, meaning you it's not drilling from the typical thing, but you use the flip cutter to cut inside. All right, then also to look at the footprint, and then to see, so you can see everything we do is very precise, meaning that really avoided the physes. Okay, so all this drilling tunnel, flip cutter, and then use the suture loop to loop around, and then the tibial guide. And so again, tibia, we're here, and then I drill upwards. So see that? Again, we don't go through the physes here, so everything in the epiphyses. Okay, so that's how it's like in the epiphyses. All right, so then with the graph, and these are, of course, all inside. So is quite, we could manage to put in quite a big one for this patient, but you can see the end. So you can see where the proximal tibia epiphysis, the button, and then the femur button, and you see the angle is a bit sharp, but we avoided the physis. So these are quite far from physis. Here also far from physis. So the key is like you avoided all the physis. All right, and again, he back to football again. Yeah. All right. So very important. We all about worry about physes. So a bit like just like your typical your physes, when it's important, when it's not important, then learn about the 7% rule, and remember the direction of drilling. If you are doing transportal and transphyseal, try to be less like creating too much surface area in your direction. So just this one is quite important if you ever deal with ACL surgery in kids. But know this, because the biggest concern, everyone, the parents ask you, will my child have a ling-lang discrepancy or valgus, varus, all that? So remember, these are the possible complications, like valgus, varus, lengthening, shortening, and the slope. So remember, because if you drill through the physes, you get destroyed. You see, destroy the physes and destroy the physes. So that obviously the one that transphyseal got the most number of damage to all the physes. And the intra-epiphyseal, remember, I drill at the epiphyses, so far away from the growth plate, but yet you cannot eliminate completely. You know why? Because as you drill, we actually create thermal damage or stimulation. So you actually lengthen you stimulate, so you actually lengthen the child's limb. All right, remember that. And lastly, the extra physeal, meaning the over the top, which just hoop around at the first case I show you, but yet even those patients have damage to growth plate as well. So this is a very important thing to remember when you advise our patients. And so remember I told you about this intra-physial. We think that we avoided everything, but yet there's a heat here, so that's why it caused all this damage. Okay. All right. Okay. So I just tell you this lastly, coming to end already, just a few more minutes. Complication and controversy of 5 common pediatric sports injuries, like we remember like ACL injuries really must be known about physis. And quite funny, medial epicondyle is so-called the sports in America, so something you need to know. And then tibial eminence is something that you need to know well as well. Okay. And then this is so-called what's new in PEDS, like ACL coronal sign, because you have this coronal LCL sign that meaning that you really be careful about how graft will fail. And discoid meniscus is actually should try to operate on them. And patellar instability, watch out for, remember the malalignment I told you about, the rotation in tibia and femur. And then shoulder, you get a lot of band lesion. Okay, so I think this is my last slide. Thank you very much for your attention. Okay, I think I did cover in time, I hope. Okay, thanks.
Yeah. So that was a wonderful talk, and I must appreciate that you are balancing at all the front. You are a very busy grandfather as well. I see your post every now and then. Yeah, so it was a wonderful talk, and we certainly have a few questions. One is from Dr. Weber. What are your return sports rate after ACL surgeries? Do you do anything else other than post-op physical rehab to tackle the psychological effect after ACL injuries?
So the beauty of because I think our athletes are still not the high-end athlete like in America. You can see that America, they show that 1/3 of them in the end back to the elite sports, but most of them 2/3 all went back to sports. So I think we are here quite lucky that I would say in my adolescent kids, I would say more than 80% went back to sports. They have no issue because these are the people, they just like it. See, sport is their identity, like my ACL, my OCD patient, right? If you tell them you need how many months, 6 or 9 months to be away from sports, they cry in the clinic, in front of you because they really wanted to be back in action. Yeah, I think it's really their identity. Yeah.
Yeah. Now, you told me you have burnt your fingers while fixing this hamstring avulsion injuries. How do you treat them now? You conservatively
No.
treat
I
them?
think actually most of them would be okay with conservative. Yeah.
Ah.
Those younger days you see people do, and then you're like, oh, I can, I will try. Chindan knows that I always try things. So dangerous.
Now, we see lots of patients with kind of miserable malalignment syndrome in our clinic. However, very seldom they have patellar instability, and very rarely they come with the knee pain. I used to see this lot when I was in sick kids, I thought that this might be due to the more body mass index or more. We used to see overweight children in my training at Canada, but now in Indian children also we see obesity a rampanting problem. So, what is your indication of correcting that miserable malalignment syndrome?
No, you actually, you are absolutely right that there are way more malalignment kids, even in patellar instability, but yet actual derotation, even by the JST hospital in Beijing, they had one of the largest series, and then they publish probably more than anyone in the world in top journals. But yet their numbers are not huge, like only like 20 or 30, not like, in the hundreds. And the reason everyone feel that unless I really need to avoided that. But I guess we can have another whole session. I did before with Shital on palsy as well on patellar instability, because that would be like a
Yeah.
huge topic by itself. But I must say that I have done TTTG, tubercle alignment, osteotomy alignment, and one of the biggest shift, I think I have shifted. I think when someone got TTTG like 30 something, and I shifted like 20, more than 20 mm, kind of thing. Yeah. So and yet, I'm giving lecture now. Call you back. Give me lecture. Yeah. So you can see that the because you know why, if you do all this TTTG and everything, it's all in the knee, conceptually, and patient feel that it's a smaller surgery. The moment you start to cut the bone and all that, people feel it's like, it's such a big one. I think Chintan, when you are with me, we did a derotation, right, in the fat boy. I don't know if you remember. Then we like cracking around using the external fixator to help to derotate, yeah, the femur and the yeah.
There was a paper I read recently. I think that was from Sweden or Norway. They followed this persistent femoral anteversion patients for 45 years, and they didn't find much problem. So they termed these as the asymptomatic anteversion patients.
Yeah. No, I think femur anteversion per se is not miserable alignment syndrome.
Yeah.
Yeah, because they don't have the associated or rather the concomitant
Tibial
tibial.
extortion.
Yeah. So and so definitely that one, I mean, the excessive femur anteversion, even worse, like a lot of time in the clinic, we call that the malalignment clinic. People really don't like to don't like to see that kind of thing. Yeah. So I'm not surprised you're 45 years of
So for this malalignment syndrome, we see femoral anteversion and tibial extorsion, but still patella is tracking okay. But so you would have a reactive strategy to that, or a prophylactic strategy, that if a patient has
I
symptoms, then
think
only you operate, or
no, patella definitely is reactive. I never do anything
prophylactic. Yeah.
prophylactically. Yeah.
Okay.
In fact, you know why I did this whole thing is because I've been going around Asia to get more interest for pediatricians to be involved in the sports instead of always our adult sports surgeons come and take over the whole
Yeah.
yeah. So because I do believe peds and you can see that Prism in America is really like is big that the adult surgeon don't dare to touch them anymore for like pediatric ACL and all that. Yeah.
Yeah, the primary reason might be the residents in North America. They get good hands-on arthroscopy training during their training, and in some part of India, we do not have much hands-on arthroscopy. That
correct. I think a lot of them, I think Chintang would testify to that. Like a lot of them get to play the scope in first time in Singapore kind of thing. Yeah. So
yeah. And so that's what I saw in my Sikh history. All the Australians, they have been doing from day one in their residency. They're putting the scope. So
correct.
Anyways, so the one last question, we are running short of time. Do you see stiffness after your trochleoplasty procedure, or they do well in terms of range of motion?
No, they don't get stiffness per se, but what I don't like them is because you see, if you don't do the trochlea flat thin enough, the trochlea won't be able to be pushed down to create the groove. But if you're thin enough, remember blood supply came from subchondral bone and below. And
Yeah.
when I do second look arthroscopy, the quality of the cartilage on top are not as
That's
great
good.
as it should be. Yeah. So that's a part that I'm a bit concerned and apprehensive. Yeah. Anyway, so I'm more like, as I say, I'm very keen that, if you have, fellows from India, where especially they have done one fellowship already, then, now we even have this extra
Interest.
remuneration for second, and these are the best kind of things to spend time here. Yeah.
Yeah. Yes, I'll definitely refer the interested ones. One of my current fellows, Weber, is going to Belgium. He wants to do hip preservation, and the another girl, Preksha, she's going to Cincinnati. So they are learning. They unfortunately, I don't do much sports medicine, but we have adult arthroscopy colleagues coming and helping us.
Yeah.
So they learn more of brachial plexus and trauma and DDH and all other stuff. So,
I know. But
but
gradually, I think
yeah,
it will, it will change the the pattern, especially because if you're more and more, do
yeah,
the Indian kids start to do more sports now?
yes. So we see lots of patients doing sports activities and sports injuries, and they have done bold because mainly for the IPL, the cricket is a religion in India. So we
Mm.
see lots of children, they are getting into academy and they're very furious. And
Mm.
the injuries of cricket are a bit different from skiing and all, but they have, as you say, Dinshaw has great experience. He has treated so many cricketers. He's very popular. So
I
same,
don't know about cricketer, but all I joke with Dean Shaw every time when when
yeah,
I'm on the podium introducing him, I always say that oh, this is Dr. Dean Shaw who is the one who single-handedly then Dean Shaw say yes, the who won the only gold medal, no more than
yeah.
for
So
India.
one of the fast bowlers of India, the best bowler in the world probably is again he was treated by Dinshaw, and he had his share of treating Indian cricketers, and now we see the cricket is very rampant and popular in each state. They have huge academies and they run these premier leagues. They are paid
But
well.
how young were they when they started this?
So
How old?
we have the leagues of under 10, under
So
15,
yeah, so
under 16, so on.
yeah.
So and then they are picked for the national Indian Premier League.
So,
So
you should see like those elbow OCD
yeah.
cases, right? Yeah, you should be able to pick that up. Hey, I saw a giant on the
Jayant, you
screen.
are there?
Is it real giant or fake one?
Yeah, Jayant is still there. Jayant is Fauzi's secretary and he has to be here.
Are you the real
Jayant,
giant or the fake one?
good
The,
morning, Jayant.
Trying
Oh,
to get my
he's on
10,000
treadmill.
steps.
wow,
That's why I was mute.
he's what, running your 5 kilometer, is it, or 10?
Yeah.
Wow. Okay, looking very
Good to
good.
listen on the treadmill to sports injuries.
Oh, that is
Enjoyed it.
even more.
Thank you.
That had even more than like more for these older than 50 and 60-year-old people who get the injury. Yeah. Okay. Good.
Right, James. I think we'll connect for more specific topics. I mean, we all would love to. We are going to conduct a module on patellar instability, and we would like to hear from you, from Sheetal, on specific subtypes of patellar instability in greater
Sure.
details with
I know.
technical details.
Yeah. I
So
love to be with
yeah,
Chita.
yeah.
We just met each other again recently. Yeah.
Yeah.
Okay, good.
Yeah.
Thanks.
So thank
So
you, and
perfect.
see you soon at Singapore.
Yeah. Hope.
Thank
Okay.
you, bro.
Bye bye. Bye bye.
Bye bye. Take care. Thank you very much for your time.
Thanks.